Okay, so now I'm going to tell about physiology of the heart. So as you can see here, this is the graph, and the x-axis, this is the volume, and here this is the pressure. So here we need to know this like really well. There are many questions from this video. So here this is the stroke volume. From here to here, this is the stroke volume. So we should know that this area is the end diastolic volume, end of the diastole, and uh, and this is also the S1. This is the point where the uh, this S1, that is our mitral and tricuspid valve actually close here. This S1 will be here, and in the two, aortic valve actually now opens. So this is the preload. Aortic valve opens, and this is the three at the end of the systole. So here it is systole over here. So systole. So what is the heart doing? So there is actually ejection systolic. Before this ejection, so heart is actually trying to accommodate a lot of blood here, and then at the three, at the point where end of the systole, well, this point is the afterload here. So from here there is going to be the diastole, that is, it's going to release up all the blood from the heart. So this is the end systolic volume. 4 is the end systolic. So this is like really important. Um, so here there are like conditions where preload is increased, afterload is increased, and stroke volume is increased. So we need to know all the type of the graphs. So we can see like the page number 297. So in this you can see aortic stenosis. So in aortic stenosis, what is happening? There is increase in the afterload. So afterload is increasing. So when there is increase, whenever we have increase in the afterload, preload and the stroke volume decreases. So our stroke volume will be like really half, and it's like really tall afterload. So in aortic stenosis, we see that, and in aortic stenosis, and when you're clamping the aorta, at that time also the stenosis of the aorta is there. So in that areas, you will see this type of the graph. This is because of increase in the afterload. So whenever there is increase in the afterload, preload decreases, stroke volume decreases, and diastolic volume decreases, and systolic volume increases. Okay, and the next is aortic regurgitation. So what is happening in the aortic regurgitation? There's like a lot of overload is there. The in aortic regurgitation, the pulse is like really very high voluminous pulses there. And so here what happens is this increase in the preload. So when we have increase in the preload, we will have increase in the stroke volume also. They're directly proportional. Preload and stroke volume, they are like directly proportional. So you will find increase in the stroke volume and increase in the preload also. So it will be like a mountain here, and this increase in the end-diastolic volume. End-diastolic volume increases, but end-systolic volume decreases. Okay, so here because of that reason, end-diastolic volume will be till here, and it will be like a mountain, and preload increases. Okay, so aortic regurgitation. So aortic regurgitation means a lot of flow coming to the blood. Okay, so where do you find this? What are the other conditions when you are getting a lot of IV fluids, and when there's a when you are getting a lot of blood transfusion, and in the patients of renal failure because they have a lot of the fluid accumulation. Then next is the mitral stenosis. So in what happens in the mitral stenosis? So in mitral stenosis, there is a stenosis of the mitral valve. So what happens here is preload actually decreases in the mitral stenosis. So preload decreases. So when preload decreases, we have decrease in the end diastolic volume also decreases. And stroke volume also decreases because they're directly proportional. So what will happen is everything is like decreasing here because the valve is tenosed, and so it's not able to accommodate a lot of the stuff. So here you will see small. So in mitral stenosis, because preload decreases, you will see very small curve in mitral stenosis. So what are the other conditions where preload decreases? So there's the medicine nitroglycerin, so it decreases the preload over here. And when you have the blood loss due to trauma or anything, when you have a heavy blood loss, so that time also there's a blood loss. So that's why preload is also decreasing over there. So you see it's very small graph in that area. And then the next is mitral regurgitation. So what happens in the mitral regurgitation? So you see lot preload is actually really increased here. So when preload is increasing, stroke volume is increasing, and end-diastolic volume is also increasing. So here you see a small, broader mountain, but not tall. If there's a preload, which you see taller and broader mountain, but if it is mitral regurgitation, so you see a broader mountain, but shorter. It's a little bit shorter. So what happens in mitral regurgitation is that because there's a lot of backflow of the blood, there's less blood in the systemic circulation. There's a lot of blood backflow in the left atrium that creates a lot of pressure in the left atrium. So because of that, what happens is that preload increases, stroke volume increases, and there's decrease in the afterload. So preload and end-diastolic volume are directly proportional. So they are going to increase, and diastolic volume is also going to increase, but there's decrease in the afterload. So what are the examples of the mitral regurgitation like situations? AV fistulas, which we give to the dialysis patients. Okay. So next is the baroreceptors and the peripheral chemoreceptors. So in these baroreceptors and the peripheral chemoreceptors, what actually happens here is that carotid sinus hypersensitivity. So what happens is that when the patient is having carotid sinus hypersensitivity, so that if the patient is actually waking up in the morning, especially seen in the old age people, when they touch the neck or when they try to adjust their thigh, they suddenly get a giddiness and they feel like they're falling down. So what actually happens is that the baroreceptors are getting hypersensitive here. So what happens is that the afferent from the glossopharyngeal nerve from the medulla part of the brain, it's going to the arch of the aorta and it's stimulating the carotid baroreceptors. So from that, what's happening, carotid sinus is now like really sending the impulses. Because of that, parasympathetic nervous system is getting activated. So when parasympathetic nervous system is getting activated, there's drop in the blood pressure and drop in the heart rate. Because of that reason, the patient will be giddy. So how can we overcome this? So what will happen? The body will try to like to save. So the saving mechanism is from the vagus nerve. So vagus nerve is a sympathetic nerve. So what it will do, it will try to increase the heart rate and it will try to increase the BP. Okay. So this is for the cardiac arrhythmia. So this is the, yeah, so this is like really important because many questions will be there on the medications, like what medications affects the sodium channels, funny channels, calcium channel influx, and potassium channel efflux. Okay, so atrial fibrillation. So atrial fibrillation, it is so mostly it's seen in the mitral stenosis and age-related also atrial fibrillation can be there. Yes, so most common symptoms will be palpitation, dyspnea, fatigue, and irregular. The pulse is like really irregular, and you can see that there's no P wave in the ECG. So one of the treatment for the atrial fibrillation is the ablation of the pulmonary vein ablation. So what happens here is because these pulmonary veins are the site of origin for the abnormal impulses for atrial fibrillation. So we are going to just ablate this because we want to stop the abnormal impulses. Okay, so now this is the action potentials. So we should know because many drugs will act on this particular channels. So here there are some drugs sodium which block the sodium channels. So there are sodium channel blockers 1A, B, C, which we will do in pharmacology section. And this is type 2 is beta blockers, type 3 is potassium channel blockers, type 4 is the calcium channel blockers. So calcium channel blockers will act here and potassium channel blockers will act here. Okay, so in atrial flutter, what happens is that the abnormal impulse, there's a lot of, so the atria is not contracting properly. It's like fluttering a lot, but it's not contracting properly. So the origin, what's the origin? Origin is there in the right atrium near the tricuspid valve. So cavo-tricuspid isthmus. So this is the area where the lot of abnormal firing is there in atrial flutter. So it is near the opening of the inferior vena cava and in the right atrium. So that is the location. Okay, so here we know the conduction of the heart. It's from the SA node to the AV node, and from there, here we go to the Purkinje fiber, bundle of His, and then the Purkinje fibers. Okay, so we have done this carotid sinus hypersensitivity, supraventricular tachycardia. So what happens is that in supraventricular tachycardia, there's a lot of impulse. So one of the treatment for supraventricular tachycardia is the carotid sinus massage. So this will actually activate the vagus nerves. Your So vasovagal and the situational syncope. This happens when there's pain, anxiety, emotion, in heat and prolonged standing. So what will happen is there increase in the parasympathetic activity. So increase in the parasympathetic activity, there is decrease in the heart rate and drop in the BP and the patient falls down. So this decrease in the preload and this vasodilatation. So but the recovery is like very quick. Within 1 to 2 minutes, they will wake up. Okay. These are the cardiovascular drugs because we should know because what all are the drugs acting at which areas. So alpha 1 receptors, alpha 2 receptors, beta 1, beta 2, muscarinic 2, 3. So alpha 1 will cause peripheral vasoconstriction and urethral constriction, pupillary dilatation. Alpha 2, this will cause decrease in the cyclic EMP and decrease in the insulin release and intestinal motility is also decreased here. Beta 1, it is cardio-specific. Beta 2, it is for lungs. It's specific for the lungs. Okay. And muscarinic or cyclic EMP, decrease in the cyclic EMP decreases the cardiac contractility. Its example is nitroglycerin. No, nitroglycerin increases the cyclic EMP, which improves the heart's contractility. Yeah. So it blocks the muscarinic 2 receptors. Muscarinic 3 is IP3, causes the bronchoconstriction, pulmonary contraction, pupillary constriction. Okay. So in congenital atrial septal defect, so in EASD, what will happen? There is fixed split of the fixed wide split of the A2. A2 is wide fixed split. So you can see that it's going to be split and split is there, but this is going to be constant. It's not increasing all the time. This is the image where there is a normal heart and this patent ductus arteriosus. So in patent ductus arteriosus, what happens is abnormal connection between the pulmonary trunk and the aorta. Okay, in tetralogy of the fire, there are four things. First of all, there is overriding of the aorta, there is right ventricular hypertrophy, there's pulmonary stenosis, and the VSD. Tetralogy of the fire. It is. Okay, so here this is the coronary autoregulation. So when there's increase in the pressure, there's increase in the blood flow, and there's decrease in the nitric oxide and adenosine, decrease in the blood flow. But when there is decrease in the pressure, but when the pressure is like really low, there's decreased blood flow, increase in the nitric oxide and the adenosine, and there's increase in the blood flow. The heart tries to survive. If there is a stenosis, there's decreased pressure. So when there is a vessel blockage of when there's a vessel blockage of the heart, what happens is that there's decreased blood flow to that area. So that area will try its best to increase the nitric oxide and the adenosine to increase the blood flow, but over the time it gets depleted. Stroke volume, it is end-diastolic volume minus the systolic volume. So this is like really important. These are the types of the shocks and what happens in them. So this is there are many questions from this area because it's like really important. So what is important here in is that hypovolemic shock. So in hypovolemic shock, what is happening? Like the patient has a road traffic accident. There's a lot of the blood loss. So what is happening? Everything is down here. Cardiac output is down. Pulmonary capillary wedge pressure is down. Everything is down. But systemic vascular resistance is high because the body is trying its best to survive. Yeah. In cardiogenic shock, what is happening? Okay, so in cardiogenic shock, what is happening is the heart is in the shock. So that's why the cardiac output is low here. So that is the only indicator. And other things are all high, but cardiac output is the only thing low because the heart is in shock. This is a cardiogenic shock. Okay, so what's happening in obstructive shock? Obstructive shock, it is seen in tension pneumothorax. So what happens in this obstructive shock is Okay, so there is decrease in the pulmonary capillary wedge pressure. So because in pulmonary embolism or tension pneumothorax, what happens is that there is increase in the there's blood clot in the pulmonary arteries. So there's increase in the pressure because the blood is not able to flow to the heart. So what is happening is that it's getting a lot of accumulation is there, and there is in decrease in the pulmonary capillary wedge pressure. Okay, so because of that, cardiac index is also low, but all other things are like high. The most important thing in obstructive shock, like in pulmonary emboli, is pulmonary capillary wedge pressure. So pulmonary capillary wedge pressure, that's the left sided pressure of the left atrium, is like really low in obstructive shock. In distributive shock, it is like the septic shock. So there's a lot of sepsis in the body. So the only organ that is trying to survive, that's trying to beat, is the heart. So here cardiac index will be like really high. All other things are low here. Yes, the cardiogenic shock. Yes. So in cardiogenic shock, what happens is that the cardiac output is like really low. So what is the mechanism behind it? Central venous pressure is actually really high. Increase in the pulmonary capillary wedge pressure, but decrease in the cardiac output is there, and this increase in the systemic venous return. Okay. So what happens in the heart failure? So pathogenesis of the heart failure. So what happens is that okay, so in the decompensated heart failure, the heart is like really failing here. So this decreased cardiac output is there. So there's sympathetic activation is there. So RAS is actually activated here, increasing the heart rate. Contractility is there because RAS is activated. There's vasoconstriction everywhere in the body. So this vasoconstriction will help in the maintaining of the blood pressure, and this increase in the extracellular volume. This is to maintain the blood pressure. Okay, so this is like really important because what happens is whenever the myocardium is stretched, it secretes the ANP and the BNP. So whenever the BNP is high, that means it's a heart failure. And the thing that blocks the BNP is the neprilysin. So this is used. This is the medication used in the heart failure. So this is like really good. It is used in together with the ARVs. So together with the ARVs, it is used. This is because this inhibits the BNP. If the BNP is less released, then the heart failure can be controlled. So what this will do, this will decrease the vasodilatation. It will decrease the aldosterone. It will increase the GFR. Okay. So what is neprilysin? What this neprilysin will do? Neprilysin will decrease the blood pressure. Neprilysin decrease the aldosterone levels and decrease the fibrosis. What valsartans will do? Valsartans will stop the vasoconstriction and will stop the fluid retention. Okay, then receptor reflex in response to the decreased blood pressure. So whenever there's drop in the blood pressure, what will happen? And is that whenever there's a decrease in the blood pressure and decrease in the heart rate, what will happen? Like it will stimulate the vagus movement that will actually try to increase the heart rate and the contractility. So in hypovolemia, what is happening? There is vasoconstriction everywhere. Baroreceptors firing will be low, and because we don't want a lot of firing to the baroreceptors, decreased signaling will sympathetic fibers, and this will increase the heart rate and contractility. Okay. In the hypovolemic shock. So what actually happens in the hypovolemic shock? In hypovolemic shock, what happens is that in the hypovolemic shock, there's a blood loss, right? So everything is down, but cardiac output is like really systemic vascular resistance is like systemic vascular resistance is like really high here. One of the things are actually low. Pulmonary capillary pressure is low. Central venous pressure is low. Decrease in the cardiac output is there. Hypertension with the age, it is why what is the reason for hypertension in the old age people? It should relate to the aortic stiffening because aorta over the time it actually becomes stiffen and stiffen. So what happens is there is elastic replacement with the collagen, increasing the pulse pressure is there, mild concentric LVH is there. cell degeneration it is slightly decreased heart rate is there and reduced baroreceptor sensitivity. And what will happen over the period of the time is reduced baroreceptor sensitivity is there. So because of the there is decrease in the heart rate and contractility. The myopericardial disease is hypertrophic cardiomyopathy. So what happens? HOCM is actually autosomal dominant disease with incomplete penetrance. It means all generations of the family are not affected here. Mutations affecting the proteins, most common is the myosin binding protein C and beta myosin heavy chain. So it is actually the myocardial dystonia and the pulmonary microvascular dysfunction. Asymmetrical septal hypertrophy is there. So it's like really important point here is that asymmetrical septal hypertrophy. The septum is actually like really hypertrophy and it is against the because of this left ventricular outflow obstruction may be there. Left ventricular stiffening will result in diastolic dysfunction and increase in ventricular arrhythmias and often asymptomatic exertional dyspnea, angina, palpitations, lightheadedness, syncope will be there. So, so what S4 is there, LVH is there, so S4 is there. Okay, so what happens in the HOCM, what is it? So left ventricular mass is increasing. Left ventricular cavity is very less here. Left ventricular cavity is like really less. Ejection fraction is preserved and ventricular and the diastolic volume is also impaired. So this is the most important thing in this table is the difference between the HOCM and the athlete's heart. Athlete's heart is also like a well-trained athlete where they will have really like a good left ventricular. They will have a muscular heart. Left ventricular mass is like really good. Left ventricular cavity size here is normal. That's a good thing. Left ventricular ejection fraction is preserved and diastolic volume is also normal here. But in HOCM, what happens? Left ventricular mass is increased, but all the things are like impaired here. Left ventricular size is low here. Ejection fraction is preserved, but diastolic function, relaxation is impaired here, right? Yeah. In directed cardiomyopathy, all the chambers are like really increased. Thinning is there. Increase in the cavity size. Left ventricular mass is increased. Left ventricular ejection fraction is decreased. Left ventricular diastolic function is normal. In restrictive cardiomyopathy, what is happening? Left ventricular mass is good, cavity is also good, but left ventricular ejection fraction is also preserved, but diastole is not relaxing properly. Restrictive, it's impaired. Diastole relaxation is only impaired here. Here you can see normal structure of the heart. Left ventricular mass is, cavity size is decreasing and its mass is increasing and enlarged thinning of the left atrium is there, dilatation of the aortic is there. High output heart failure. So in how high output heart failure like AV fistula. So what happens when there is a AV fistula? It's a high output failure. So what happens? Everything is increasing except systemic vascular resistance. It is decreasing. Pulmonary artery catheters they form in the right atrium like this in the ventricular artery. Then test is the Purkinje atrial, then ventricular. And it is like the really fastest, then the atrial muscle, and then the ventricular muscle, and then the AV node is the slowest. SC node and AV node is the slowest. So the is very fast, super fast from there. Sodium blocker will actually act here. So the blockers, then potassium channel blockers, they will act in the 3, and the calcium channel blockers will actually act on the 2. And there is actually a tachycardia, the decrease in the myocardial perfusion. S3, it is seen in the dilated cardiomyopathy, it is seen in the dilated cardiomyopathy. S3 is seen in heart failure. As for receiving the LVH constrictive type with the alveoli or the restrictive type because it's not relaxing properly. Endothelium independent vascularization. So what happens is the endothelium independent vascularization is alkaline particle and as you trust, they will actually try to think that the nitric oxide and nitric oxide will convert GTP to GMP, GMP accumulated within this vascularization. Pressure plus pressure. Tricuspid regurgitation. The tricuspid regurgitation is best heard at the second and third intercostal spaces and it increases with respiration. VST it is heard at the third or fourth intercostal space. It is loud. It is murmur is usually loud and it is accompanied by a thrill. Yeah, the mitral regurgitation is best heard at the apex, but mitral regurgitation and best heard at the apex at the fourth intercostal space. It relates to the axilla. So what happens in the mitral stenosis? Mitral stenosis, this valve, this increase in the pulmonary capillary wedge pressure, increase in the JVP, increase in the coronary central venous pressure, increase in the JVP, the hepatomegaly, edema is there, orthopnea, present in subcorticus, cardiac, with the control dyspnea and the fatigue. So mitral stenosis, so what you will see, left atrium normally it should be here, but it is actually there, upper mitral valve. Mitral. So in mitral stenosis, what kind of the thing will you see? So in mitral stenosis, the left atrial pressure is like really high. So preload actually decreases here. So preload decreases, so small volume, small volume mitral stenosis. Okay. Preload is actually less, stroke volume is less, and absolute volume is less. Okay. This is like really, really important. This is the point where the mitral valve actually opens here. So this S1 is actually good here. Okay, so S1 it is the mitral valve bicuspid valve closure. It is the loudest at the mm, this one is actually here, and then this part is sorry. So mitral valve closes. So when mitral valve closes, you will see S1 and S2 here. Mitral valve and tricuspid valve where it closes, you see S1 and S2 here. And during aortic valve closure, P2 and A2 here. And here, this is the point where the aortic valve actually opens here, and this is the point where aortic valve closes. And here in and outer, there's a dichotic notch will be there. This is the left ventricular pressure. Over this side, this is the left ventricular pressure. So here atrial systole is there. Isovolumetric relaxation or contraction. Isovolumetric contraction is the point where you see S1. Isovolumetric relaxation is the point where you see S2. As a ventricular filling. S3 and S4. Rapid ventricular filling is 2. So what happens in the aortic regurgitation? There's a lot of blood coming without actually. So here you see 20, 160 blood is coming. Also this backflow, right? Aortic regurgitation, yeah. So VSD, what happens in the VSD? Right and left ventricular pressures are equal. So in the postnatal transition, there's increase in the systemic vascular resistance increases. Right ventricular volume overload is there, and pulmonary reservoir circulation is there. In the VSD, there's a right to the left shunting is there. Okay, so what happens? So when you do exercise, what happens? There is an increase in the heart rate, there's increase in the cardiac activity. If there's increase in the preload with exercise, there's increase in the preload is there, and arterial dilatation will increase the blood supply to the muscles. Okay, so we are done with the physiology.